Welcome, everyone. Thank you so much for joining us. We're going to be started in just a minute here. Our platform's letting everyone in, so hold tight and we'll be started here shortly. But in the meantime, feel free to use the chat to say hello, give us a greeting, let us know where you're tuning in from today. We would love to hear from you. You will notice as our platform lets you in that your cameras are automatically off and your mics are muted. So you won't be able to turn those on. So we encourage you to use the chat today to ask your questions, make comments, and share in there. Welcome, welcome. I see our numbers growing. Great to see you all. Just as we're letting our platform let everyone in, please feel free to use the chat, say hello. I see some of those greetings coming in. Welcome, everyone. Thank you. Great to see you. All right. Well, thank you for joining us today. We're going to go ahead and get started. Welcome to today's webinar, Prioritizing Healthcare Worker Emotional Wellbeing Across the Country. And this is part one of our two-part series that will be happening today and tomorrow. So welcome. My name is Jackie Zimmerman. I'm the Public Education Associate at Mental Health America's National Office. And I am joined here today with Jenny Sanchez, who's also from our national office, and some wonderful affiliate members from our MHAs across the country who will be really leading and sharing during these sessions today and tomorrow. I have just a few notes for you all before we go ahead and get started. This webinar is being recorded and will be emailed out to all registrants within 1 week. We currently do not offer CEUs, but if you would like to request a certificate of attendance, we have a form to request one. I will share that in the chat later, and then that will also be sent out in your follow-up materials where you can request a certificate. We will not have time for live Q&A today, but please feel free to share your questions in the chat, and those will be shared with our speakers, and the answers will be sent to you in your follow-up materials. So we encourage you to use the chat today to ask questions, share your own knowledge and comments in there. And with that, I'll hand it over to Jenny just for some additional welcome.
Thank you, Jackie. Good afternoon, everyone. Thank you for joining us today and tomorrow. As Jackie mentioned, my name is Jenny Sanchez, and I work for the National Office of Mental Health America. I'm the Director of Grants Management and Projects, and I'm joined here by my colleagues who are from some of our great affiliates, and I'm so pleased that they'll get to share more with you about the pilots that they've been leading over the past 12 months. I want to just highlight some notes about where this project came from and what our focus was for this. It's no secret that the impact of COVID-19 on frontline healthcare workers has been devastating. Healthcare workers face increased risks of coronavirus exposure and poor mental health outcomes. Healthcare workers have dealt with and are still experiencing stress, burnout, fatigue, grief, and anxiety during the pandemic. We also know that hospitals and health centers are high-stress workplaces that experience staffing shortages and long hours. Many supports have been focused on doctors and nurses, and not always the support workers, such as certified nursing assistants or other professionals such as maintenance and janitorial staff and food workers. Additionally, many healthcare workers are wary of seeking help because they fear retaliation in licensing or credentialing, or because they know too many providers in their networks and there's a lack of trust there. So to address this, Mental Health America worked with MHA affiliates across 5 states to pilot several evidence-based projects to serve healthcare workers and their families. Efforts were focused on promoting and supporting the emotional and mental well-being of frontline healthcare workers and healthcare workers in the supportive roles, some of which I mentioned before. And to equip them to overcome challenges created or exacerbated by the COVID-19 pandemic. Mental Health America is in a unique position because our federated affiliate model, we often say if you've met one MHA, you've met one MHA, as each MHA affiliate offers different services and programs that are responsive to the needs of their specific communities. So because there were 5 different tactics chosen for 5 different populations in 5 different geographic regions over the past 12 months, MHA was able to test several models of culturally relevant and sustainable support for healthcare workers in each community. So today you will hear from Mental Health America of Los Angeles, who piloted a resilience and skill building training program, as well as Mental Health America of Montana, who piloted a tribal and rural healthcare support warm line. So at this time, we have a video to share from our affiliate in Montana.
As I'm sharing this, I will note, if the audio is quiet for you on the video, feel free to enable the captions, and we do have closed captioning available.
Hello, everybody. My name is Shelley Ani. I'm the Executive Director for Mental Health America of Montana. We are still getting snow, so if you are in warmer climate, please send that to us. We desperately need warmer weather. We are all done with the winter. I want to first say thank you to our funders for this amazing opportunity, and to MHA National for giving us this grant, and especially Jenny. She has been a great piece of this whole work that we do, and so thank you very much. I also want to say I'm sorry I could not be there in person. I have a prior commitment next week, so I apologize for that. So our MHA of Montana proposed project was to establish a telephonic healthcare warm line for all frontline workers, mental health education events for healthcare settings, and educational presentations to community chamber of commerce on how best to support their community healthcare workers. We will continue to maintain collaborative partnerships with the state and local chamber of commerce and the Montana Hospital Association, and we'll continue to collaborate with reaching all the healthcare workers here in Montana. Additionally, we will collaborate with the Alliance for Tribal Healthcare Workers, which represents the 7 tribal nations and their healthcare centers, to provide education and support to all tribal healthcare workers through their community with the tribal warm line. I apologize if you hear any kind of ruffling noise. That's my bulldog, just making a whole lot of noise because I'm not paying attention to him. So I'm sorry for that. The impact would be to provide them with an anonymous community to gain support for their mental wellness, to find resources within their communities, participate in a virtual support group session, and reach all 57 counties and facilities they work in, to include critical access hospitals, rural health clinics, trauma centers, and urban health centers and hospitals, all of which we received a total of $50,000. I'd say that our successes in our project were many. And we had the majority of all our callers come from Montana. We also have had callers outside of Montana, which we never turn away, due to a nationwide trend to eliminate their drop-in centers Maybe they cannot get a hold of their therapist, their counselor, family member, friend, you name it. Some just call in um, because that social piece has been eliminated out of their life for some time. So they call in, and I just needed someone to say goodnight to, and we get those callers. Um, However, 85% or more of our callers were directly from Montana. Um, we do ask what county they reside in, and some just will not give us that information in fear that we are going to know where they live. And that's all right. We understand that. But based on all the callers that we received, I say that we reach the majority of all our counties. Um, we've partnered with great organizations. One of, Montana Hospital Association. They hold all the contents really for healthcare, frontline healthcare workers, doctors, nurses, and such. And so they've reached out to their network. We've also have a running relationship with the Chamber of Commerce. Our newly partnership is Carroll College to bring in some interns. So those that are going through the mental health field get um, a little bit of their background on the warm line. We don't do any kind of advice or counseling or such, but they do get the sense of the people in the community and their needs. We also partner with the Montana State University here and a few other partners that have emerged over the course of our grant. Looking back to my last report in September of 2022, I think I was just looking for the data on healthcare workers in general, and I really needed to take a step back and look back at the fields that we would not really be looking at, but should be looking at that do offer some kind of support as far as the mental health well-being. So in the report, you'll see that the following data is responders, EMT workers, emergency department staff, home health aides, hospice care, provider's office, hospitals, of course, foster care, individuals that wouldn't normally call us do call us. And obviously the mental health field. And as you can see from the report, it outlines who we reach that may be part of the healthcare system in total. And I think that we can expand that demographic to almost anyone in any field. We know of a janitor at the school helps a kid find resources for food, clothing, somebody to reach out to because they're living in their car is just one example of a community going beyond their job description. Our challenges were many. One big challenge was securing access to the tribal nations. We do have some responders that are tribal members, and they did reach out to their tribe. However, it was just a difficult task. We did reach some. 5 to 8% of our callers who identified as a tribal member did call our line. So we are very thankful that we did reach those individuals, and we will continue to reach out. We've also had some challenges with the new 9-8 that has launched in July of last year here in Montana. We ended up having a lot more crisis calls than we would have normally had prior to it launched. We have 3 call centers here, and I think that it was just not a well thought out plan of how everything was going to be handled. But what I will say is that the individuals that had called our line, that had experience with calling the 988, had not experienced it as a helpful resources. So they call us, or we've had calls be transferred directly from 988 to us. So we do, and we do have some responders that have worked on the crisis line before. So that has been very helpful in helping with assessment, which we would normally not do on our warm line. However, if a call comes in and that person is struggling, then they do assessment. They've all been trained to do that. Maybe do a QPR, see what that action was, see where they are, and just get them to a place where they're able to function. And that's what it is to get them back to a pre-crisis level and get them functioning so that they know that they need to eat, they need to drink, they need to put on clothes, they need to, you know, get to work, get to the store, whatever it is. So we do that. However, if the if the caller is far beyond that crisis, then we do send in the proper authorities, which is get a welfare check, call law enforcement, try and get them to have a family, friend, whoever, come get them, take them to the emergency room. There are some mobile crisis units here, but it's just in rural areas, there are none. And some of the rural areas that we have, people travel 5 hours just to get to a provider's office or to even see their therapist. That's where we are. Those would really be my challenges during this project: tribal nations and handling of crisis calls. In the world today, everything seems to be a crisis. Our mental health systems are failing here in Montana. The workforce has depleted. Resources are few here and there. So how do we get help to those that are needing that mental health piece? I do not have the answers. I wish I did, but I don't. I just know that our warm line is the prevention piece. If we do not add more prevention here to Montana, then we will continue to fail on all sides. So the other piece is, what should other organizations that might be interested in doing a warm line or doing the project that we were doing? I would say do your homework. Have that conversation. Sit down with your team, your your bosses, whatever, the community leaders, stakeholders. Get a hold of your senators, your representatives, state officials. See what really is still needed and how reaching out to the communities would benefit of having a warm line. Making sure that you have good collaborative partners, because I got to tell you, not one organization is an all in it. Sometimes I feel like some of our communities are in that place where one organization is all in it and you just can't get anywhere, and you're failing your community. You're not helping your community by building more relationships and building that partnership up is going to make your community succeed and flourish. And that's exactly what needs to happen. And also see, what does the warm line look for you? What are your hours? How many responders you're going to need? And what kind of training you will need to do to benefit not just your responders, but to your callers as well. So that would be those first steps. MHA of Montana would like to find more resources, obviously, and funding to continue our work and expand our hours to 24/7. That is how we like to scale up. There is a much need of prevention here in Montana, and we've talked about it before, and that is this piece, is the prevention piece. The callers that do call, thank us very much for being there when they couldn't get a hold of somebody. So that makes it all worth getting the line up and going. Impact on our marginal communities, it's barely even being talked about. However, our line takes all callers, no matter what community they're from, because we believe that everyone has their own story and they should be heard. We are also looking at turning on a youth line soon. We've been working with a group of youth since 2021. They're very powerful speakers. They already know where they're headed. I know when I was their age, I don't know, I had no idea where I was going. But these kids are just so beyond our century right now. And so thankful to have them on our board. They created a board. They have their name, they made a mission, and so they like to turn on a line to help their peers. And they also want to do a summer camp, because the summer camps here in Montana are all led by the churches, and not everybody is a church person. So we are looking to do that fairly soon. So obviously we're looking for more youth, and obviously the funding, because we do pay our responders, and we also will be paying our youth to manage the line. So it's all really managed by youth, run by youth. It's all about empowerment, which we are also doing our annual conference. I'm super excited about it, if you can't tell. All about youth empowerment. And these kids are going to bring it. They are it's a safe place for them to share their voice to whoever wants to be, whoever's going to be there. We have some really great speakers coming on board. Anyways, I know it's not part of the project, but I just thought I mentioned that. I just think it's going to be amazing. So anyways, I want to say thank you very much. I was a little bit nervous, but thank you to the funders again for this great opportunity, and MHA National. Jenny, you've been very awesome to work with, and I hope to work with you continually in the future. And should you have any questions, please let me know. I'm sure I can get those answered via email through Jenny. So thank you. Have a great day.
I want to say thank you to Shelley for providing that overview. And I want to mention, as there were some comments and questions regarding the report that she was talking about, I will address that at the end of today's webinar with some next steps for tomorrow's session. This is information that you will all receive, and I want to highlight that through the warm line that Shelley was talking about, over 4,200 healthcare workers were served through this line with an overwhelmingly positive response. We can share that data with you afterward regarding how over 80% of callers who were identified as healthcare workers were also, they felt that this was a valuable, helpful service. We have data on the support that was received and any follow-up action that they've identified to take forward. So with that, I want to turn this over to Mental Health America of Los Angeles with Chris Miller. And
Hi,
Luther.
everyone. Thank you so much, Jenny. Can you hear me okay? We had a little bit of technical problems before. It's really been an honor to work on this project. It's been wonderful, collaborating with the whole group, and we're just thrilled to have done it. I want to do a little brief overview about our agency. We're a fairly large 400-person, soon to be 100-year-old organization out that serves all of LA County. We serve people with integrated mental health care, medical care, wellness services, employment, housing, and we try to bring whatever someone needs to what they're dealing with. Historically, we served those with the greatest mental health needs. A new direction that our organization has been going, especially since the pandemic, is to really look at the continuum of needs that people have and viewing mental health not just as a binary either or where you have a mental illness or you don't, but rather as a situation where everybody has mental health needs and they vary at different times. And we saw during the pandemic that those can become very strong. We actually began the precursor to this, which is called Project Resilience, a couple of years ago as an effort to provide resilience skills and coping skills to the community at large. And then when we heard about this grant, we were thrilled because we were thinking one of the areas we wanted to work in was for people who were healthcare workers, to help them deal with the trauma they had been through and to fortify them against trauma that would be coming up. And so we launched this project, and it's changed a bit. There's always things you don't anticipate that happen, but in many ways it made our project better. We started off by doing interviews to see what the needs were. And we found that there were many, as everyone knows, among our healthcare population. But I want to just start by doing an overview of what our intervention was. We sought to serve at least 200 healthcare workers. We ended up reaching 207. We were hoping to hit at least 2 different medical centers, and we ended up serving people from 28. We found that it was very easy to get people to participate. There was a real desire to be involved. But I'm going to start by turning this over to my colleague Luther Rickert, who's our Chief Services Officer. And he's going to tell you about the initial pilot we did to really understand the needs of the people we were going to serve. So I'm going to introduce Luther and let him start that. I think you're muted. You're muted, Luther.
Good morning from LA. I know it's not morning for everybody out there, but thank you, Chris. I'll talk a little bit about how this started for us. Here at MHLA, as Chris mentioned, we were already involved in a lot of things that we thought would be useful to frontline healthcare workers. And like many on the call, we were reading the headlines and we were horrified. At the time when this funding came out, it really looked like it was a moment of truth for our healthcare system, with widespread burnout and trauma happening among frontline healthcare workers, and a real crisis and potentially a crisis for our healthcare system for years to come. So we'd already been discussing it when the funding came out. When were awarded, we really wanted to shape this around what are the needs of the healthcare workers and how can we best meet them. So we thought, logically, we would reach out and get feedback from them. And since we work with interface with many healthcare providers, we kind of reached out on the administrative level where we received a lot of validation and encouragement at first, but then it really didn't go anywhere, and so we kind of went into another gear where we were like, well, we actually interface, we're the largest, one of the largest frontline social service providers in Los Angeles County, and we interface directly with a lot of healthcare workers, and we just started interviewing and talking to them directly. And what we were getting was, first, we did find out there were a lot of tensions between the healthcare workers and administration, and that had to do a lot with scheduling and the pay rates of people coming in from outside to supplement the workforce. There was kind of a labor crisis going on at the time. And there was just a general lack of trust. But we did get a lot of feedback from them, both on and off the record. And some of the themes that the common themes that started coming out that really helped shape this project. Number one, there definitely was widespread trauma and burnout among frontline healthcare workers. Just like we saw in the headlines, we were hearing similar stories, and you see some similar stories in our report from the participants, from the feedback. And we also realized that the things that we had been doing were definitely going to be of benefit to them and be able to serve this slightly different population that we were used to serving. Another thing we got a lot was people were exhausted, and there was huge demands on their time. So they really wanted something that was very flexible and that they could meet at their own, that they, didn't have to be somewhere, sometime in particular, So things like online, things like video trainings and things like that. We really heard that over and over again, that's what people wanted. And the next big one, and this was one that kind of really surprised me and made me realize we got a lot of work to do in the healthcare lines. There was a lot of fear and anxiety and stigma about participating in mental health services, and people really felt that it would be held against them if they knew, if their colleagues or their administrators knew that they were going to be there. So anonymity was very high on the list of something that they would value. And so that's kind of the feedback that shaped our what turned out to be highly successful project. And I guess I'll turn it back to Chris.
Thank you, Luther. So with that feedback, we altered what we originally started out with. We were going originally to do a lot of this in person, and we decided that doing it remotely would be really of benefit. And we decided to try to cast as broad a net as possible to recruit, because we understood from the people who were interviewed that they didn't really want to be in groups or disclosing things with colleagues that were at the centers where they worked. So we had a lot of representation from a lot of different medical centers in the end. But let me talk a little bit about the intervention that we did. What we wanted to do was give them a breadth of resilience skills and exposure to it. What that included was first of all, it was self-care, managing burnout, things like how to get a good night's sleep, how to ensure that you know how to sleep, relaxation, meditation, different practices that could really help them manage their stress. The next part was how to make decisions and take actions that would help manage stress and issues with other people in relationships. How to ask for what you want, how to set clear boundaries, how to really determine if their relationships were helping them or causing stress, and what adjustments to make if they were causing stress. The next part was about internal regulation. What do you do when you're feeling anxious? Of course, they could go see a therapist, but we were trying to give them techniques that they could use on their own to understand when they had anxiety and how to cope with it. We also had a big piece of it on trauma, like explaining what trauma is, giving them some tools to actually cope with that trauma and to deal with it. And so there was a broad array of topics that were a part of this, and we integrated them into one package that they all received remotely. There's a second part to our intervention, and this we had to adjust. We originally wanted to have this built into our website where anyone could come on to the website any hour and interact in a remote mode around issues they were having. We found that the technology connected to that would slow us down so much that we took another approach, which was to develop videos. And we've designed 8 videos in areas. I can read off the topics. One is the art of sleeping, communication and relationships, trauma, coping skills, burnout, self-care, goal setting and resilience plans. We thought it was really important for people to have a plan for how to manage their stress and increase their resilience. And then a broader video on what is mental health in general. The content of those videos are made, and we actually ended up going to a particular vendor in Denmark and they're going to be done in an animated form. Those are being finished up right now. Those are going to be available to everyone who did our initial presentations. We asked them if they wanted to join a network of people who could have access to skill building materials on an ongoing basis, and to a person, everyone joined. So that was great. So let me talk a little bit about what results we got. First of all, a bit about the population. The age breakdown of the people we served, most of them were between the ages of 25 and 60, but 6% were 60 plus. We had, as is often the case in the healthcare profession, a majority was female. We had 11% who were LGBTQ plus. And one of the things we were happy about is the vast majority of those we reached, over 80%, were BIPOC and people of color. Only 19% were white or Caucasian. And so that range of backgrounds was something that we really appreciated, because one of the things we had heard from the BIPOC community was how much they were suffering at this time with so many different things going on. And so one of our goals was to reach as diverse an audience as possible. And one of the reasons we opted for the videos to be in animated format is sometimes in a video, there's one person talking. We wanted the little characters in the videos to be someone who anyone could identify with, regardless of their age, their background, or anything else. One of the things we gathered information on was barriers during the process of this. And we asked people what gets in the way of their self-care. And it broke down in the following way. Family responsibilities was 9%. Not enough time in the day was 21%. Money cost too much was very little, only 2%. Work was 11%. All of the above combined was 49%. So one of the things we worked on, and our videos are working on, is how to deal with those barriers, how to make sure that you make time for yourself to engage in the resilience practices that we taught them. In terms of the outcomes, our goal was to really reach 2 medical centers. We ended up hitting many more than that with the 81 that we got. But the other goal was to reduce the amount of burnout and stress they were experiencing, and to really increase their resilience and their confidence in their ability to bounce back, at least by 20%. We hit those goals across the board. We measured the concept of wellness by a series of questions that asked them about how happy they felt, how healthy they were, and how in control of their lives they were. At the end of the program, a full 91% rated their ability to increase their overall resilience and wellness as moderate, which was really good. At the beginning, it was only 37% of the participants who felt they could do that. And then in terms of their confidence in their ability to bounce back, we operationalized resilience with a metaphor of bouncing back, kind of getting back to baseline and recovering from stress. We found that following the trainings, when asked about their confidence and their ability to bounce back, 51% reported being confident, and another 9% reported being extremely confident. So it reflected a 26% increase over where they were in the beginning. It was 34% prior to the trainings. So these were very cursory measures, and going forward, we'd like to continue this. We'd like to do more of the measures prior to the intervention so that we can make the measures a little more robust. But we were encouraged that these were indications of the fact that it really helped them. So that was really good in terms of the success of it. In terms of what we learned, one of the questions was what we learned from this, was basically that we really have to find a variety of ways to reach people. And one of the good things that came out of the pandemic, I know there were many difficult things, but there were some good things, was being able to use Zoom and a remote platform to reach people. That allowed us to get to so many more people than we would have been able to reach. It protected them in terms of anonymity. So going forward, we're looking to get new funding we now have our training modules. We're very soon going to have an array of videos that we'll make available to basically to everyone. We want to keep making those. And so we're in the process of raising funding to continue this, because we'd love for it to share it with people and for it to go on. And it's a model that can be easily reproduced because it can be done by Zoom. You can do it with anyone, anywhere in the country, to really introduce them to resilience skills. And as I said, the challenge of measuring, we want to measure the impact. We'd like to make that more robust, but we were happy to at least come up with something we could insert into the format that we had to get an idea of how effective the program was. I wanted to I want to go to a testimonial from a particular person who was actually a chief of staff in a large medical center. It was probably one of the most touching testimonials that I read, both in terms of what she had been through before. What she said was, okay, let me read this because I think that would be easier. She's a Hispanic female working as chief of staff for a large community health clinic. I've been working in this field in some capacity for 11 years. My husband of 42 years passed away in June of 2022 after a long illness. I am blessed with 3 beautiful daughters who I am very close to. Being in the healthcare field placed me front and center with the daily focus on COVID. It felt like it consumed every minute of my day. It was challenging being screened daily and masking and retaining staff. In addition, the focus of our work became screening, testing, and vaccinating, and applying for funding to assist with the added duties. I did not experience COVID, but my husband and 2 of my daughters did. The virus exacerbated my husband's chronic illness and escalated his death. Being isolated and consumed with illness resulted in my depression. I believe over the last 2 years, I was grieving his loss even prior to his death. After his death, I spent a lot of time with my daughters, and this was very helpful. And then when we asked her about the impact of this, she said, I enjoyed the sleep techniques, especially, and mindfulness, because that has been an area that I have struggled with. It is also therapeutic to know that I'm not alone and that I had compounded trauma and that I was coping in my way with the pandemic, the stress of healthcare, and the loss of my husband one day at a time. This helped me stop and reflect and appreciate my inner strength. But those were the kinds of personal stories that we heard from what people were dealing with. So we felt honored to be able to offer this, and we felt honored to be a recipient of this funding, and just to get these kinds of tools to the people who had really been in the front lines of this. In terms of, one of the questions asked was, can this be scaled up? And the answer is yes. Because it's in a remote format and we're using videos, we hope we can expand this and get it out to as many people as would want to use it. We would probably work on changing some of the content of the Zoom sessions because we were focused a lot on pandemic issues. And now we're hopefully coming out of the pandemic a little bit. And so we want to make it generic and something that will apply to people at any time. But I still think it will. There was a lot of discussion about what was going on during the pandemic. So scaling it up is something that I feel is very feasible. And as I said, in terms of challenges, the greatest ones were the technology ones. And Luther's interviews in the beginning were invaluable, just because you you decide to do something and you think you sort of run in and you're going to try this. And then, you know, we were surprised by people not wanting to be in groups with their peers. We originally thought we would go to different medical centers and meet with staff in groups, and learning that they didn't even want that was really helpful. My colleague who is going to also present on our recruitment is ill today. So I wanted to say a little bit about that. And this has to do with why I feel this is a scalable effort. I was blown away by the number of medical centers we got. And once we started reaching out, people started sending emails to their friends who are nurses in other centers. And there were people, when we finally saw where everyone was from, we had no idea that the effort would go that far. So that was really fun to see, and great to see that there were so many from the north end of LA County all the way down to the very south end. I don't know if those on this call know how big LA County is, but it's kind of like a little state. So it was a very huge geographic area we were able to reach in LA County. So that's what I had in terms of what I wanted to present about what the impact it had.
Thank you, Chris and Luther, for presenting and for sharing about your work with this project and all of your findings over the course of this last year. And just a reminder that questions are being collected and will be answered and addressed in the follow-up materials. Also, so for tomorrow, please, we invite you to come back for part 2 of the series, and you will hear from our other 3 affiliates about their pilot projects and their approaches, their geographic region, their successes, their challenges, and what they found with their work, how scalable their project is for other communities across the United States, and how replicable it is. And so we look forward to hearing from the Mental Health Association in New York State. They provided a life coaching program called the Mental Health Association in New York State Care Path Program. There was workplace wellness for hospitals conducted through Mental Health America of Greater Dallas, and help for support staff by Mental Health America in Montgomery in Alabama. So those are who you'll hear from tomorrow. And to wrap up the webinar series, at the end of the session tomorrow, you'll hear more from me after we've heard from the affiliates what MHA National did with these items, these findings, and stay tuned for a report to come out on this. And we look forward to seeing you back soon. Thank you so much.
Thank you all. Have a wonderful afternoon. Thank you, speakers. Thank you, Jenny. And thank you to Shelley, who shared via video with us. Just a reminder, it is being recorded, and this and tomorrow's session will be sent out to everyone. So if you can't make it tomorrow, you'll receive the recording for both. So thank you all. Thank you, Chris and Luther. Thank you, Jenny.
Thanks.
Thank you.
Have a great rest of your day, everyone. See you back here tomorrow.